thank our partners for this event, Sanciel, ANA New York, ANIA. Thank you so much for your partnership for this event. And we also, yes, give them a round of applause. Thank you. And we also want to thank, there's the slide for our planning committee, and we also want to thank our planning contributors and partners who have done so much free work out of their own time, all weekends and throughout the night to help make this event possible. So thank you very much to all of them. We really appreciate it. And last but not least, we'd like to thank our sponsors. Our event would not be possible without all of these amazing sponsors helping support our event and support nurses and our community. So thank you very much for all of your help. And we are so glad that you are here. Without further ado, I have the honor of introducing our sponsor panelists. Michelle Burke here is the Assistant Vice President of Clinical Informatics at Northwell Health, where she develops and implements clinical information system initiatives in inpatient clinical informatics and nursing departments at Northwell. She holds a BSN from York College of Pennsylvania and an MSN in Nursing Administration and Informatics at Malloy University. She's also an adjunct professor with LIU and Hofstra, and she is also the ANIA New York Tri-State Chapter President. So we're very happy to have her here. I'm also going to introduce our moderator at Rochester. Dr. Marilyn Dollinger is president of the American Nurses Association of New York and professor emeritus at the Wegman School of Nursing, St. John Fisher University in Rochester, New York. After 15 years in practicing in adult critical care, Dr. Dollinger moved to academia. She held both faculty and academic leadership positions, teaching across undergraduate, master's, and doctoral programs. She's a graduate of the University of Toronto, Russell Sage College, and the University of Buffalo. Dr. Dollinger is an active advocate and lecturer for legislative, regulative, and health policy issues. Dr. Dollinger is a past member of several regional and state nursing organization, public policy/legislative committees, political action committees, and community not-for-profit boards. So thank you, Michelle and Marilyn, for helping us to kick off this event. And I will hand it off to Marilyn, who's going to start our panel. Oh, I apologize. Michelle is going to start first.
Well, introduce your panel first.
Yes, thank you, Romina. So Marilyn is going to introduce our panel at the New York site, and then she'll hand it off to Marilyn, who is going to introduce our speakers at Rochester, and then Marilyn will start the panel.
I have one. I'm connected. Okay, and let me just make sure my microphone is secure. Well, we have 4 lovely panelist speakers here, and I'm very happy to introduce them. Kathy Mazza, right there. This is not in order. PhD RN, MBA, is a senior advisor strategist, population health informatics at Northwell Health. She's an adjunct professor in health informatics master's program at Hofstra University School of Health Professions and Human Service. In her role at Northwell, she is responsible for identifying technical solutions to support clinicians in value-based care models, chronic disease management, and patient engagement. Her doctoral research was focused on the use of chatbots to gather patient-generated health data to reduce avoidable hospital readmissions. Iris on the end in lovely yellow. Iris is the driving force behind Northwell Health's telehealth service as the VP and leader. Her role involves expanding telehealth initiatives across the organization and its communities. Iris earned her BSN from University of Bridgeport and her master's in nursing administration from Adelphi University, where she received her Gertrude UG Scholarship Award. Committed to improving care for at-risk populations, she has been actively involved in community and professional organizations. Iris has spoken at numerous prestigious events and chaired various healthcare associations, demonstrating her dedication to advancing telehealth and nursing education. She currently serves on the advisory board for CTEL, advocating for telehealth at the state and national level. Jessily Ramirez-Mendoza has a European Public Health Master's and an International Master's in Public Health. Holding these degrees from renowned institutions in France and Spain, Jessily is fluent in English, Spanish, and French, enabling effective communication across diverse teams and sectors. She drives interdisciplinary collaboration across the Americas and Europe, focusing on patient-centered healthcare and AI integration. With 16 years of experience in healthcare management and research, she specializes in implementation science, advocating for nurse researchers and youth involvement in AI design. Skilled in strategic planning and innovation management, she fosters multi-stakeholder initiatives to improve pediatric and adult health. And lastly, Denise Quail has a BSN, and she serves as the Director of Nursing Informatics, Operations, and Staff Education at NYC Health and Hospitals Community Care. A member of the New York State HIMSS Nursing Committee, co-facilitator of the New York State Epic Home Care Operations Group with over 20 years in nursing. She is a certified Epic clinical instructional designer, an Epic training environmental designer, and leverages clinical experience to co-create an EMR experience that supports evidence-based practice and quality assurance of provider documentation. She's an active member of the Nursing Informatics Council at NYC Health and Hospitals, promoting nursing informatics and professional development for the healthcare team. And now I will hand us over to Rochester.
Thank you, Michelle. It's my pleasure to be here and to introduce our panel here at RIT in Rochester. You've already heard Dr. Hasselberg's bio, so I will not repeat that. I will bring to your attention, it was a little bit of a game time decision whether or not he would join the panel. And you've all heard of health equity. Well, we decided we needed panel equity. We were not going to let the city outdo us with 4 panelists while we only had 3 in Rochester. All right, so our first panelist I'm going to introduce is Annette Macias-Hoag. Dr. Macias-Hoag is the Executive Vice President, Chief Nursing and Patient Care Officer at Rochester Regional Health. With over 25 years of nursing and executive experience, she previously served at the University of Vermont Health Network. There, she integrated nursing care system-wide and collaborated with the College of Nursing and Health Sciences. Dr. Macias-Hoag's innovative leadership includes developing care models like the Acuity Adaptable Unit. A first-generation college graduate, she holds a bachelor's in nursing, a master's in healthcare administration, a doctorate in nursing practice. Certified as a nurse executive advanced and in executive nursing practice, she actively contributes to professional organizations nationally. Next is Dr. Rosemary Ventura. Dr. Ventura is the Chief Nursing Information Officer at the University of Rochester Medical Center, revolutionizing the role of nursing informatics. With a background as a critical care nurse, she earned her MA in Nursing Informatics from NYU and a DNP from Case Western Reserve University. Dr. Ventura seamlessly bridges the realms of technology and clinical care, boasting extensive leadership experience in IT implementation across complex healthcare systems. A trailblazer in nurse informatics, she has shaped industry standards and competencies, contributing to textbooks and national organizations. At URMC, Dr. Ventura ensures nurses have a voice in technology adoption, fostering systems that prioritize both caregivers and patients. And Jenna Kowalski. Jenna is currently the Vice President of Clinical Innovation at Health Recovery Solutions, an innovative health technology company specializing in remote patient monitoring. She has over 10 years of experience leading remote patient monitoring programs, and now at HRS for 3 years, consulting with over 350 organizations across the country. Prior to HRS, she worked at Catholic Health System of Western New York for 17 years, starting in the hospital and working her way through various leadership positions. So that's our board, and we have the opportunity to begin the questioning. So, Michael, you did a great job teeing it up and giving us a lot to think about. I know my mind is blown listening to some of the things you were talking about. Rosemary, I'm going to start with you. From your perspective, what is the importance of informatics in healthcare delivery?
I think it's everything, but I might be jaded. So make sure I will try to keep this question in succinct manner. So I think that I've been saying this for a very long time, having been in informatics for a pretty significant amount of time, at least at this point, that this has become an absolute foundation of clinical practice. And you can see that evolution has really been sort of much more adopted from a nursing leadership perspective than ever. They are seeing, meaning our CNOs, all of our nurse leaders are starting to really understand, number one, what is it that we do? We've only been in a specialty since 1992, but it seems like they're finally catching on to what is it that you do? And so with all of that said, and a lot of it was catapulted, and I see a lot of shaking of heads, it was catapulted through what I think Dr. Hasselberg has presented, which is finally people understood the value of what these technologies could do in terms of access for patients, resources for nurses, and how does it ultimately make my life easier. As an informatics team, one of the things that I am seeing is the pivot of our role. What we did in the 2000s when I first started, we were just trying to implement. If you remember, that was, before CPOE. And what I'm trying to tell our group and explain to our organization is we are no longer just the EMR system supporters. That's our bread and butter. I will not deny that, but we are so much more in terms of what can we use technology for and leverage in order to make it easier for our patients and our nurses. All of that said, as an informaticist, our key role is not to overburden our clinicians with technology, because at the end of the day, we're not help desks, we're not technicians, we are nurses, and we're trying to deliver care and deliver models of nursing and models of care models, I should say, that are different, and that's great. But we have to all change as an organization to support that. You just can't throw more devices and more tools on the backs of our nurses. So while it is important, I'm the first person to stand next to Michael and all of our other nurse leaders to say we need to do this, but it has to be somebody in the room to say it won't be a nurse who's handing out this iPad. It won't be the nurse who's going to manage this account on the iPad. And so I think that that's just one example of how I see informatics and the role of our informatics team evolving, because we're much more the voice. And we always say we're those translationalists. We are those liaisons. But that has become even more apparent how valuable it is in order for us to be successful.
Thank you. Annette, what role do nurses play in shaping the future of healthcare at informatics? So how can interdisciplinary collaboration between nursing, technology, and other healthcare fields be fostered to optimize patient outcomes and improve healthcare delivery systems?
Thank you. Thank you, all of you, for being here this evening. I'm sure you all had a full day of work. So really excited about the discussion with Michael, because I'll take you back when I first started nursing. It's been over 30 years. I still was wearing my white nursing uniform with my nursing cap. And I never imagined that we would be doing some of the things that we are talking about this time, because I was lost without my, documentation form and my plan of care that was all written. And so now when I go at the bedside, if the system goes down, I freak out because I can't be without those nursing flow sheets and, in our EMR, and you give me a piece of paper along with, some of our newer nurses, and they're like, what are you doing? What are we doing? And so, so going back to, the question about the collaboration, nursing or healthcare, I should say, it's a team sport. It's not just nurses working on their own. We need our providers, our, others like PT, respiratory, et cetera. And how is it that we can together care for our patients in a better way? Transitions of care are extremely important, and we don't have time to be picking people out to say, oh, I need to do this next, or I need to do that. What do you need from me? And so for me, having the technology to be able to put it all together really enables not only the nurses, but the providers and others to really take a holistic look at, of the patient. So then we can have great communication and therefore great outcomes. For me, I see nursing informatics as that glue between operations and clinical practice that helps us improve not only patient outcomes, but really will help us improve satisfaction of patients, the families, and our staff and providers as we move through the different technologies. I love what you said, Rosemary, that we cannot continue to give people devices. We need to talk to our regulatory partners like CMS. They continue to, give more and more regulations for nurses and also providers to document. So how is it that we can make it easier for our nurses and providers and not have this documentation burden? It's extremely important for all of us to be involved in ensuring that that doesn't happen or continues to happen.
Thanks, Annette. Jenna, can you give me an example or two of an innovation in virtual patient care that you think is underutilized, and perhaps some of the reasons behind that?
Thank you for having me, by the way. I feel just so blessed to be with this panel and the experience that is sitting right here. So thank you for having me. I would say that all of virtual care is a little underutilized. Not in every health system, but in many health systems. And it continues to be, part of a strategy typically in the health systems. They talk about it. We want to implement this. We want to do this. Without great leadership, without great vision, without objectives and goals for that specific desire to incorporate virtual care and technology in general in the health system, you have to have someone at the top. And I look at Michael and I hear what he just said, and I say, you're a nurse and you're at the top and you're leading these digital strategies. We don't see that everywhere, a nurse leading those digital strategies. So I think that's so important to hear that, to see that. I travel around the country and I talk to, C-level executives, and there may be a nurse or two in the room for sure. We do have some chief nurse officers, chief CNIOs, but it's just not everywhere. So I think that we really need to start with some leadership and really start driving virtual care, because we're looking at solving these problems that we've been dealing with for many years. COVID exacerbated staffing issues, but we always had them. Let's be real. It just got worse. So I think that we have to utilize these technologies, not just virtual technologies, but AI and a lot of other things we're seeing, all the wearables, all the fancy things that are out there. They're all great. But we have to have a vision behind it, because otherwise we're just slapping another wearable on someone and saying, we're going to do that, right? We're going to do that in our CHF clinic. We're going to do that in hospital at home. we have to come together and centralize that and use, one or two vendors, not 50, and not be siloed where we don't know what we're all doing, right? So we know from the, the nurse informaticists in the room are shaking their heads no, because you're being asked to help in this individual, the next technology, the next great thing. And they're all great things, but we just have to have, a good mind behind it. But I will say I do have two things that I'm interested in that I've been following very closely. Virtual nursing, obviously in the inpatient setting, it's up and coming. It's not something that's really seen in every health system. I certainly don't see that in the health systems I visit. In New York, I'm from New York. I live in Florida now, but I'm hearing so much innovation in New York, which is really exciting. But the virtual nursing piece, I think, can be really an integral part of solving that problem of really dissatisfied nurses and really helping with burnout. So what you were saying earlier resonated very much. And then virtual nursing and home health. I don't know if there's any home health people out there, but it's my heart. I was in home health for many years at Catholic Health. I just love it. And I think that innovation in home health, I will say Catholic Health had remote patient monitoring 25 years ago. And you wouldn't know that, right? But we really, it's a very interesting place to start virtual nursing. I could talk a lot more about that, but that is another one I really love too.
Thank you. So, Michael, last fall, we had the opportunity to be on a panel together for the Strong Professional Nursing Council. And you made a statement, and what you said was AI will not replace nurses, but nurses who use AI will replace nurses who don't. And I know you were addressing the little bit of fear that was coming up in the audience when they were thinking about this. So can you give a few words about why nurses do not have to be afraid?
I mean, I don't remember making that comment, but I'm not. First off, I'm not surprised that I made that comment, and I do believe that. I think I talked about it in my keynote. I mean, there are things that we do in clinical care that a machine can't do, and one of the downfalls, in my opinion, of Watson Health was, where IBM tackled first was clinical and medical decision making. That is where they wanted to leverage AI. And there's an art to clinical care, and that is something, again, I don't think a machine will be able to replicate. And to be frank, that's what we enjoy doing. That's what we went to school for, was to do clinical decision making. And focusing efforts on replacing that, I think, will never work. That being said, there is power of these tools to take off of our plates things that nurses should not be doing.
Scheduling.
Yeah,
And you fix our scheduling problems with AI.
Yes.
I agree. All the administrative burden that is placed on nurses, nurse managers, all of those folks, get rid of all that stuff. Automate those processes so we could focus on clinical. I didn't mean to interrupt you, but I can't help myself.
No, that's why we work so well together, Rosemary. We fill in each other's words, but that's where I think the power is going to be. And nurses who don't embrace that, I do think will be replaced, and the nurses that do, will find more efficiencies, more joy, and less burnout. And so that's where we should be focusing our effort.
Thank you. And I want you to know I quote you frequently using that term, but I always attribute it to you. I always make sure you have right. So at this point, we're going to turn it back to New York City and Michelle and your panel.
Okay. Well, that was some really good conversation. Very exciting, sparking some fun over there. I want to continue a little bit about, you brought up virtual care. So I want to ask Iris on the end a little bit about, when implementing new technologies in virtual care, what are some of the considerations that organizations often overlook?
Oh, so that's a good one. And it really dovetails really well onto the conversation we've already had. The biggest thing is the voice of the customer, right? And who are the customers in the technology that you're involving? It's the nurses, for sure. Bring them to the table, designing the workflow. Not all the parties are always at the table. Bringing in the shiny new toy and not really knowing the problem you're trying to solve. Huge problem. Lots of shiny toys sitting on a shelf collecting dust that the kids don't want to play with. And then I would say not just the voice of the nurse, but the voice of the providers, because it's a team event, right? We just mentioned that earlier. We have to be able to play in the sandbox together. The other piece is in healthcare in general, I really believe we try so hard to get to best that we don't stop at better. And that burns us out because we are so busy at the drawing board trying to design and redesign that we don't go and try to test it out. We're so afraid. And this exactly is the conversation you had earlier. I keep looking behind me because everybody's behind me but I'm looking at Rochester. You know, we want so much to do well. We want to do right by the patient. We want to do right by the nurses that we're almost afraid to put our toe in the water. And we have to get over that. I mean, there's fear, AI is going to do this, AI is going to do that. No, it's going to help us. And we may hiccup along the way, but you can't be afraid to fail. Just fail fast and move forward. I know I did a lot of phraseology here. I'm apologizing, but they're my favorites because they're mantras that I live by and that my team lives by. I think the other piece around this is bringing a patient to the room when you're designing. And this is something that seemed old and new at the same time. You know, we've always talked about you have to talk to the patient, but we don't often bring them into a planning session. And so one of the goals I have, and by the way, just so that you know where the world is going, I mean, my title was VP of Telehealth. My title now is VP for Operations for the Center for Virtual Health, which is a new endeavor for us, which is to really pull all of the technology into a wholesome, across the continuum care regime, because we do not have that right now. We have silos of care. And you as nurses know how bad that makes you feel, right? Because you cannot communicate from one to the other easily. We need to fix that with technology too. We need to bridge the gap without taking away the human factor. And that has been a big piece of my philosophy. And by the way, I have years of critical care in my background. So I've dealt with the difficult, and I've also dealt with the fact that, you know, oftentimes things are bought with the thought that, oh, this is going to solve all the problems without really understanding the etiology of the problem. So technology is one solution, but the human factor has to be in there too. I can tell you a time, just as an anecdote, as an example, where a hospital I worked in my past clinical life bought a really high-tech portable monitor / defibrillator / Swan-Ganz monitor. You know, you name it, it had it all. And the rep from the company brought it in, and I said, okay, I was a nurse, a critical care educator at the time, and it was my job to in-service the whole staff on it. So I said, okay, give me the lowdown. And he sat there and went, well, you can push this. I said, well, what does it do? What is it going to do for me? What is it going to do for my patient? Could not answer the question. And so I said, okay, where did you drive in from? And he said, New Jersey. And we were out in Long Island. I said, you should go now because it's probably rush hour. And then I sat down with the manual. So this goes to the informatics behind this, right? And I figured out how that darn thing worked. And I was there for 6 or 7 hours. I took it apart. I took everything out. I put it back together and I said, okay, this can make our life better, but not the way he showed us. So that's nursing informatics, right? Taking it and making it work for you. And I've also been known to take things that were designed for one thing and use them for another to make life better. And truthfully, during COVID, I did a lot of that, but we did have an infrastructure before that. So I was very fortunate because we had EICU. I stood up. It was the first full-scale EICU that stayed open and is still open in New York State. And so it grew very quickly just before the pandemic, and we were able to leverage that. So that was some of your earlier virtual nursing, and the first EICU actually opened even before that. Columbia had done it here in the city even before us. So it's been around for a while, but we kind of put it back in the closet for a while and forgot about it. We need to take it back out and improve on it now that we have AI to add to it.
Okay, thank you very much. So, Iris talked about, things that have been overlooked. So Kathy, this question is for you. What are some critical gaps in population health that might go unnoticed, and how can technology help us address them?
High tech. I've been a nurse for a while, and it's really an exciting time. I say to friends' kids are now in nursing school and medical school. I've reached that point, and I say to them, "You're coming in at such a great time." Like, I joined nursing like 3 weeks before DRGs were initiated. All I've gotten is payment reform for like a lot of years. And now we're getting to this place where we can know our patients differently. And the way that the market has changed is driving these population health initiatives. Patients are not inside of our walls. We're the old term, they're going home quicker and sicker. I did home care for a long time, home infusion. Patients who were receiving drips that I gave in the ICU at North Shore University Hospital, I was giving at home, and it blew my mind through the 90s. Like, wow, look what we're doing, how high tech we are. And patients are changing. They're consumers. They want the same convenience in healthcare that they have with scheduling appointments to get an oil change done on their car or handling their banking records. They get copies and they can download them and share them with their accountant. Try to get your CAT scan. It just doesn't happen that way. And then we have the value-based care initiatives driving how payment happens for us. And we have a foot in both worlds right now. So that's a little interesting because we have some patients that we make money when they come to us, and we have some patients where we save money when they don't come to us, and and trying to navigate all of that. And then we have this technology that's accelerating at a pace that, frankly, healthcare has never been great at adopting technology outside of the ICUs and those settings where we really love it and can't wait for the next bell and whistle. Look what it took for us to get electronic medical records, literally like an act of Congress. Like, it really, like, we fight this stuff. And so I think the alignment now with population health initiatives to keep our communities healthier, to keep individual patients healthier, the quintuple aim is really where I see technology taking us. Keep our patients healthier, our neighborhoods healthier, satisfy our patients, satisfy providers, and reduce inequity in care. That's like, I tell people that's my job description, basically, in population health informatics. And technology can help us to know who's out in the community in trouble, who's failing and is going to be in the emergency room. And so I think we have lots of opportunities, and technology can drive us in the right direction.
Okay, so Denise, I will dovetail on that. Talking about, population health and the patients being sicker at home. What opportunities do we have in community nursing, and how does informatics play a role in addressing these opportunities?
So first, I want to thank HIMSS and New York State Nursing Committee for inviting me here. I appreciate that. We have a lot of critical care gaps in home care. And one of the things that informatics can do is really help with clinical decision making, and especially around mental health and assessments in mental health and home care. And some of that is driven by our CMS and our OASIS data sets, but like in maternal child health, we don't have that structured in as a regulation in data sets, right? So we can help there, and we can help with design of assessments and make them more natural within the workflow. We can drive data, right? And pull data to make sure that patients are safe, that clinical managers are following up with abnormal results. We also could use nudge technology and make sure that clinicians are asking the right questions, getting the right assessments, right, depending upon the patient population. So yeah, that's what we can do.
Great, thank you. And lastly, Jessily, informatics can help augment capabilities to deliver care, but how can technology help us safeguard our own well-being as we take care of others?
Absolutely. I think, we think a lot about patient first. And in this question, we are also sometimes the patient, right? And so I want to kind of change that a little bit. We are the human, just like the patient is the human, right? And so I think we can leverage a lot of these tools to lessen our work. And I know that the question for me was a little bit different. So if I may go back to that, Daniela, I apologize because it's a really important issue I wanted to call attention to. And it was piggybacking off of your question about gaps in care. And one gap in care that we may not have a crystal ball for, but we do have predictive analytics and line of sight to is the transition of care between pediatric patients and their transition into adult care. How many of you here are working in peds? Raise your hand. And in Rochester? Excellent. Couple there in the back. How many of you are preparing to receive patients who are coming from a pediatric care model? Right. So 12 to 26-year-olds make up about 20% of the population here in the US. That's millions. Out of those millions, 25 to 30% have to live with a condition. They're born with it or acquire it during childhood. And they learn and grow up and learn to manage their care as best they can. Informatics is a tool that we have here today to really leverage what is so innate in this next generation in terms of how quickly they adopt technology, how they incorporate it into their daily lives. And so I think there's untapped potential there for them to participate in the design, like you were saying, Iris, and for them to have agency in their care as they transition during those teen years.
Thank you very much. Yeah, some of my history has been in pediatrics, and I really like that perspective that you just brought to the table, to the discussion. So Marilyn, I'm going to transition to you.
No, Michelle.
Oh, I'm sorry, Marianne.
Okay, we have a couple of questions and
Oh,
had
okay,
already, like a
lovely.
lot of good questions. So we're gonna have to let whoever wants to answer this, I think is the best way, instead of asking someone, who feels most appropriate to answer. So the first question is, would this AI technology possibly be used for dictation by bedside nurses for head to toe assessments? For example, a nurse could potentially state, for patient X, all systems within defined limits except for crackles auscultated in anterior lungs. That was the first question. Where are we going with that? Who wants to answer that? Rochester or New York?
Yeah. Oh, yeah.
Rochester.
Yes, we'll take
It's
that.
already here. That technology's already been deployed. Nurses are using that right now in practice to do exactly what you just said. So yes, it's here, and it's very exciting.
I think the biggest part of that question is that we're not all aware. And so I think we need to do a better job, because certainly, Michael, you have a very niche sort of scope in your role, but how do we spread that? How do we, as educators in informatics, how do we become aware of what's going on? I think is super important, because then we can advocate as well as, continue to mentor our new nurses and our older nurses who are there on what's coming up to make it easier for them. It's not always easy to stay current.
I think it's this networking that we're doing so we can all learn from each other, because we should be sharing this. So that's great. Thank you so much. So the next, Okay, the next question is, are hospitals taking on the liability of the AI? I saw some of the generative AI responses signed off as the RN or MD. That makes me concerned that the AI is learning to be a provider and a nurse and won't be able to distinguish rules surrounding behavior. How are we ensuring there are no hallucinations occurring in responses if they are responding to 1,600 messages a day without oversight?
That question's directed to me. It's a great question. You know, I think
Little bit.
that, you know, the regulatory space for generative AI is still forming. You know, the Biden administration put out an executive order to essentially mandate that the different agencies under the federal government start developing regulations, policies, guidelines around AI and liability. And it's not clear yet. Those guidelines have not come. Now, for us at Rochester, who, you know, is starting to look at the potential of these technologies and tools, you know, we are looking at minimizing the liability by targeting applications that there's still that nurse in the loop. So with those patient messages, you still have a nurse that, you know, validates, you know, whether or not it's appropriate or not appropriate to be sent out. You know, I think it's going to be a while before culturally, it just across the country and society, you will be ready for this technology to directly interface with patients. And we're just not there yet as a country or as a globe of what that liability and regulatory landscape is going to look like.
Thank you, Dr. Hasselberg. Okay.
Okay, and so now we'll pass it back to Rochester.
Great, thank you. Annette, this question's for you. As a CNO, what challenges do organizations have in implementing innovative technologies?
I think several, but the one, and we haven't talked about generational differences. And it's about what is it right now, we're in this weird space, I think, that we have people like me that grew up on paper and perhaps it's difficult to, you know, get the technology and understand it. I mean, we know a lot of nurses left the bedside when the medical record, electronic medical record came on board because they didn't know how to handle it. So how is it that we train people to use it effectively? It's going to be really important. But also, I think we're at a point right now that we need to think about what our nurses that are coming out of school need, but also what healthcare is going to look in the future. Otherwise, we are not going to know or how to meet everybody's needs. So let me give you an example. I started looking at some data as to why some of our nurses are leaving at year 1 and 2. Part of it was they didn't feel like they were, you know, prepared well enough. But as I started to meet with them, you know, we're giving them binders to fill out their orientation and all of that. And I'm going to give here a shout out to Atharva Medkar, who's over there, because I reached out to RIT and I said, how can you guys help me develop an app that is going to meet the needs of a nurse coming in to be oriented? And that nurse can use that, thank you, through their lifetime of learning and keep it with them so we can, you know, see the trajectory. And he's doing an amazing job. And I hope that we can be done soon. But again, it's just, what is it that they need? I think the other piece, and I think somebody talked about lack of leadership and investment to support some of the technology. Many people may not understand why it's important to have this technology, and we do need those investments. And what's the first thing that gets cut usually? Educators, nurse informaticists, and the IT budget. And so how is it that we can support that moving forward? Because without that technology and without that infrastructure, we're not going to survive in healthcare. I got it.
Thank you. Thank you. Jenna, this question's for you. When new technologies in virtual care are implemented, what are some of the considerations that organizations often overlook?
That's a really hard one. I think that, I said it earlier, I think that they often overlook including the nurses in the room to give perspective, right? You know, how is that technology going to help solve this problem that we're talking about? But they also forget to incorporate others that should be in the room, right? From the organization. It was physicians. It really has to start you know, communicating from the top, but we have to have communication even before you bring in the technology. Your organization should be talking about the future now. And we're talking about nurses, right? We should be talking to nurses at every level about the future of nursing, about the future that technology is going to bring. So if we're talking to them now and next year we decide to bring in some element of AI, they're ready. We've been talking to them. We've been showing them, you know, webinars. We've been showing them, you know, having them reading articles. There are so many great articles out there to be reading, and so many good journals that we could be bringing that they don't necessarily take the time to read. So we can bring them into our team meetings. We can bring them into our huddles. We can bring them in, you know, anytime and start talking about that as leaders, nurse leaders. But challenges in implementation, there's a lot of them. I would say one of the biggest barriers is identifying the folks that have trouble really referring and understanding the patient population that your technology is going to address. So making sure that we have and we understand the amount of patients this technology will address. If we go into this and we, you know, niche little thing and we say we're going to address X disease and this issue is maybe not as large as we thought, and we go in and we don't look that it's really only 500 patients, you know, when we thought it was 12,000 patients, right? So we just really have to understand that. That's one of the big ones.
Thank you. Rosemary, what external partnerships and collaborations can we leverage or learn from to advance innovation in informatics when looking at care gaps?
So interesting. I think one of the biggest thing I've learned recently, very funny, I know, and I learned this in school, you know, community nurses, for all the community nurses and the home care nurses that are on in this forum. I'm so excited because one of the things that we have done, I think, is to give you an example, we never talked about home care. We never talked about patients outside of a hospital in any administrative boardroom that I have sat in the past 20 years until recently. Until COVID, and when we started talking about determinants of health disparities. And that conversation really only started 2 years ago. And so for me, what I have learned that has become so important is we use the term holistic care, thinking about patient-centric care, but we were really not practicing what we were preaching. And so one of the most important things that I've learned is understanding what those community resources are. So if we find a patient that has a food disparity, what are you supposed to do? I'm like, oh my gosh, I don't know. Meanwhile, there were experts right there. They were like, well, we have community resources. We have FoodLink. We have all of these specific sort of partners. And quite frankly, it astounded me that I, as a nurse leader, didn't know. So that means I could not communicate to our nurses why the information of gathering a disparity is so important, because then we could connect those patients to these appropriate resources. And that was huge for our nurses. It wasn't a matter of, I just want you to document more stuff. It was because they could, that could connect the patient to a community resource that we had no idea about.
All right, Michael, now this may be a little bit of a curveball, but I'm going to ask it anyway. So you're a psych mental health nurse practitioner, as well as all your other credentials. How have those skills supported your work that you do in AI and working with all of the people?
You know, when I started my career as a psych MP, it was actually fairly early in the psych MP movement, and my first job out of school was in a rural part of New York State because I actually couldn't find a job in Rochester. They didn't know what psych MPs were or what psych MPs did. And, I was commuting from Rochester an hour and a half, almost 2 hours one way to get down to this rural part of New York State. And I was the only psychiatric provider for 6 counties. So I did, the jails, I did the nursing homes, I did the psychopharm clinic. And so if you needed a psychiatric medication, like I was the only one that would prescribe it. And it really hit home to me how resilient these rural communities are and how grateful they were that someone like myself who had this specialty expertise was driving down to their communities to provide care. And that ended up becoming my why in healthcare was, how can we get access out to communities that otherwise wouldn't receive it? And so that was really my driver. And early in my career, my big claim to fame was developing a telehealth program across the state of New York before telehealth was cool or even reimbursed in the states. And that went from can't take on any more patients because I can't grow the psych MPs any quicker. So I had to move into other technologies to think about how could I use technology to get care out to these communities, but without needing a human on the other end. And so that's kind of what brought me into AI and mobile apps and VR and kind of other innovative technologies. But it was really that, starting my career in a rural part of New York State and loving it, that drove my passion.
Thanks for sharing that. Great answer that I had no idea what you were going to say answering that one. So thank you. All right, we're going to throw it back to Michelle in the city.
All right, thank you very much. As I'm sitting here and we're asking some questions, some of the questions may be similar, but all of you really represent, as we talked about the title of the presentation today, the symposium, is that you all come from a different part of the continuum of care. So while you may hear some of these questions that may seem similar, it's really your perspective that you're bringing forth. So let me get to the next one. Jessily, can you share an example of your work with teams around patient-centered informatics?
Sure. And the marquee definition of patient-centered care is really that we have data that can bring patients and clinicians into conversation, and it allows them to have agency in their care and participate in their care. I've had the pleasure of working with teams here and in Europe to develop sort of versions of PROMs and PROs, patient-reported outcomes and patient-reported outcome measures. And this is just such an untapped opportunity in terms of, being in an age where we have so much data, as our keynote speaker explained. How do we cut through all of that, right? From a clinical standpoint, I want to offer that PROMs and EPROMs, they offer us an opportunity to stay human and to bring that through informatics into the patient-doctor and nursing team encounter. And to remember that, what we see in the data is one story, but we always have to pay attention to the patient in front of us. Sometimes, many times, there's human error in where this data comes from. As our keynote speaker mentioned, not all of it is quality data, right? And accurate data. Chief complaints are missed, right? And so I think PROMs are just a tool that we can use to remind us of being present in that patient encounter and remind us, that it is about a person and their outcomes of health.
Thank you. Denise. Jumping around. Informatics can help augment capabilities to deliver care. How can technology help safeguard our own well-being as we take care of those patients in your framework?
That's a great question because home care is decentralized healthcare delivery, and we can leverage wearables and mobile technology to really keep our staff safe and augment situational awareness. We just had an earthquake in New York, and it helped with mass messaging. Geolocation helps us track staff who have not been able to check in yet, right? And just really check on patient safety and nursing safety. So I think that tech can really help us keep our nurses safe, can really help us with our emergency preparedness plans. As informaticists, we can bake that in to those workflows and make it effective in all of our healthcare settings.
Wonderful, thank you. The next question is for Iris on the end. She's special, she has her own microphone. How do you envision the trajectory of nursing in the next 5 to 10 years in the landscape of technological innovation?
So I think that we're kind of there already. I just think bringing nurses to the forefront, the perfect example is look who your innovation person is at Rochester, right? A nurse. Yay. Why? We're in it up to here, right? We've touched every piece of healthcare over the years. And I think it's becoming, we have more and more CEOs of hospitals that are nurses that are running the hospitals now. It's not your traditional role. And then they have that business background. And then there's the technology piece layered on top of that, making the job easier and allowing them to be able to think outside of the box. I think embracing it now, true to that statement that was a quote about if nurses will embrace AI, they'll be the ones that'll be there. I believe that we have a generation that's already embraced technology that's coming. And it's also another piece around this is as that new generation comes to the forefront and they're in the clinical settings, those of us like me or a little older, age out. We don't have to age out of the field because of the technology. We are finding ways even today in things like the tele-ICU, but beyond, it's that education. And the one thing you cannot replace on a nurse yet is that nursing intuition. You're not going to get rid of that. And that touch and that empathy piece can be done remotely. And so you can get a nurse that would have normally retired and extend their careers. So you're going to see, I think, the nurses that want to embrace the use of technology to share their lived experiences, to help the next generation of nurses to maybe improve that empathy. There was a period of time, there was a gap where we had such, and I'm going to tell you as an educator, where there was no eye contact between nurses and patients because they were so affixed to the stuff in front of them. So that happy medium is, I think, on its way because of that same technology, ironically.
Wonderful. And our last question is for Kathy, and it's the same question, but again, from your perspective, how do you envision the trajectory of nursing in the next 5 to 10 years?
So I loved all of that. I really feel that we're at this kind of transition point. I'm hopeful that informatics will be so embedded in nursing curriculum that it's not something you go do later. It's understood. This is part of nursing, like auscultation, like pharmacology, like anything else. The use of technology is part of our job description. It's what you do. I think nurses who I've seen are resistant think it may depersonalize the experience. And so I just want to share 2 quick anecdotes from recent experience with our use of chatbots to reach out to patients who were recently discharged from the hospital. Is the first instance. Very high-powered exec here in New York, home following a hospitalization for heart failure. And he was receiving a morning chat each day. A chatbot looked like texting, but he was answering some questions about his symptoms. And his he recorded a weight of 194. I'm making up the number. And his weight had been 191 the day before, which we know, okay, this is a heart failure patient who is going to be in the emergency room by Saturday. And it triggered a red alert on a dashboard for a nurse who called him. And he was puzzled. He didn't understand why he was getting the call. And he got a little agitated. And then he said, wait a minute. Are you telling me that you're calling me because my weight 8 minutes ago was 194 and you know that? And the nurse said, yes, you're up 3 pounds in a day. And And he said, I rang a call bell in the hospital last week and I couldn't get a nurse in even. And so it does, can make it more personal. And then another one that was perhaps even more poignant was a postpartum one when we were using chats to monitor how the baby's doing, how breastfeeding's going, and postpartum depression questions. She had an in-office visit that day. Everything was fine on her visit. She went home and completed the chat and admitted that she had suicidal ideation. And when asked about it, she said, it was easier for me to tell it to my phone than because my care team has been following my pregnancy. They were all excited about the baby. And so we think it's depersonalization. And for some patients, it actually enables them to connect with us and be vulnerable. So we have to let go of some of our own preconceptions.
So that is extremely powerful.
Thank you.
Absolutely wonderful. I think we're going to take some questions from our see folks. Audience.
All right, so we've got time for some questions from the audience here in Rochester. So what are your questions? Okay, in the front.
Terrible at asking questions in one sentence. How do you think nursing informatics can transform the community and population, like general population health, what we can do as nurse informaticists to help empower community to be healthier, to keep them out of places like the hospital, or how to manage those chronic health conditions?
If I may,
I can take.
Oh, go ahead. Okay, thank you. Patients are out there generating a ton of data. If you're wearing an Apple Watch in this room, there are things we could know about you, your activity level. So even something as simple as a Fitbit on a geriatric patient who's gone home, if their steps were 400 yesterday and they're 600 today, cool. They're probably, getting back to their routines. If they're still 300, 300, 300, they got used to being in the bed at the hospital and are not getting back to their routines. So I do think technology has a lot of potential to help us know what's happening outside of our walls and intervene in a timely manner before they've had the change that they can't recover from.
Annette, go ahead.
Yeah, I just want to add to that as a nurse executive that, sits next to the CEO and our COO. For me, it's important to look at our data. So we ask a lot of information. So how do we use that data? And it is important to form our strategy on how to take care of the community by looking at the data that we are asking nurses, providers. And as a nurse informaticist, to be able to help us and not only design how we collect the data in a more efficient way, but also how is it that we can provide it to our providers and to our CEO and others to be able to make those strategic decisions is extremely important. So thank you for that question.
All right, we've got another question.
Thank you so much, Alexis Ballinghaugen. So we talk about technology, we talk about, adopting it, integrating it, but we haven't talked about the literacy part for both our patients and for our clinicians. Can we speak about that?
I wrote that down because I think it's extremely important in terms of informatics competencies. That's a big term. You read it everywhere. It's hard to implement. And we really need to be thoughtful and mindful. We focus a lot on new grads, new people, new orientation, but what are those competencies that are necessary throughout the life cycle or the lifetime of the professional? We cannot even keep up with what our patients know. And so it's really hard for some, going back to the first question, which is how do you support our communities? How do we as nurses, as informaticists, a lot of that is educating our own nursing teams to understand what these technologies are and translating that for them so they can then translate it for our patients. I don't think we focus enough on those skills at every single level from an executive down to the bedside nurse. We have to put in programs within our organizations. Absolutely, it starts in school and we're working on that. But as an organization, we need to be much more thoughtful about what is it. And it's not just about an implementation of a technology. It is about what does this mean when I am practicing? And that has to come over time.
Thank
I
you.
would say also it's what does it mean to the community? Because, for example, I think about my 84-year-old mother who has Alzheimer's, and you give them an iPad or something to go ahead and do her own, I don't know, registration for the clinic appointment. She doesn't know what to do with that. She can't comprehend. So how is it that we then also tailor when we have these technologies to think about those that cannot use them? It's going to be really important.
Thank you. And now we'll send it back to New York City for questions.
I just want to comment on that. I mean, health literacy is certainly something, but one of the things we forget about, and it's not just about informatics, it's about navigation. And so one of the things we learned pretty early on with RPM, right, is you really need somebody to handhold you through this. And I just had a personal experience with an elderly family member that went home after having a pacemaker and had a foot of the bed detector and forgot to use it when she had an event. Why? Well, nobody really navigated her through the education. Nobody thought about using technology to record the information so she could go back to it later, because telling somebody something on their way out of the hospital after an event is overwhelming. They're already thinking, how am I getting home? Where did my shoes go? They're not like thinking, I have to hit a button if I get dizzy, you know, and they're thinking, well, their problem is solved. That health literacy has to be partnered with somebody that navigates the system. And you all know, if any of you how many of you have been in a hospital? A fair number of you. And if you already know the back roads, you still probably had some kind of encounter difficulty. I just went through heck, I'll be polite, and we know what to do. So imagine the complexity. Now you're handing them technology on top of that. We have got to be prepared to support the programs we develop. So the navigation can't be left out of the program. And by the way, none of us, no man is an island. We cannot do this by ourselves. We have to do it as a team.
And technology can help there in other ways too. We use telehealth now with patients. We can use it with families. We're doing the education about your new diabetes diagnosis. Is there a family member who we can dial in on this? You're going home today with this piece of equipment. The daughter's at home waiting for the hospital bed to be delivered or the oxygen or whatever. Can we dial her in and get her in on your discharge instructions and record this so that you have it to show other family members? Just starting to think differently than we've done before, because this technology is new to all of us. Let's use it to its greatest power.
We have a question.
Thank you. Oh God, no, I'm not dressed to be on the camera. No, no, no. Hi everybody. Well, my question, I'm just like in awe of like all of you guys. My name is Tatiana, and my question just really comes down to like, we talk about technology as like this amazing resource. However, it is an expensive resource, and so when it comes to population health or community health, these are spaces where there's no resources or limited resources. And so like I often find myself just figuring out how to even introduce like, you know, access to patient portals for people who don't know how to use like, you know, like Windows XP, like like I know we're like way beyond that, but like I have people who still have like computers with Windows XP, and so like we're talking, what is that, Windows 2000? Yeah, but and so like I guess what's your vision in terms of like addressing this inequality, right? Because like this is a huge barrier to like making sure that everybody's health outcomes improve, but without the resources for people to, use those tools, like how do you even address it? Like, yes, the government should fund it, but what other tools are out there?
For population health, we look a lot to grants. We do go to organizations that are trying to solve some of these problems in the community, and they're receptive to this kind of technology. We have an initiative starting now with a local Jewish organization to do walking for seniors, just getting them in, giving them Fitbits, getting them walking, counting their steps, getting them engaged in social activities and activity tracking. But you're spot on. This is, we may make the disparities worse as we try to make them better for a little while. And then I'm just going to quickly get on my soapbox and say that I now think that internet service should be like the fire department and the police come when you hit 911. We need internet for everyone. It's not a luxury anymore. It is how you get your health care these days. So.
One more question from the audience?
I did want to make a comment, and it is important that we are cognizant as nurses about increasing healthcare disparities, right? Diminishing access, very important. I think that a lot of our home care nurses are very creative about what they recommend to patients and family members to get them access. Sometimes, like, they know the laundromat down the corner has free Wi-Fi. And so they're very creative, but you're right. We cannot make this a greater problem, right? We cannot have people not being able to manage their diabetes just because they can't get on a portal and use something, right? To speak to their provider, right? Great question. Thank you.
Good evening. All right, so I just want to say thank you, everyone on the panel. It's been great. I know Michelle, and I know Iris very well. I used to work at Northwell for quite some time. But my question is really going back to nursing schools. So there's a lot of new technology, and a lot of times, especially with virtual nursing, virtual sitting, things that would make a bedside nurse's life easier, right? Because a lot of times we only think of the virtual care or the virtual staff, but it's really augmenting the care of the bedside. As we think about these new technologies, what I don't see is a lot of it in the nursing schools, or at least broaching the subject or talking to them about it. So where do we feel as nursing informatics going back to the schools and saying, these are the new technologies that are coming. This can make your life easier, because at least from personal experience, my whole family's full of nurses, right? So thankfully, I was lucky enough to get into the unit and the hospital that I wanted to. My sister didn't. So her first year of nursing, a lot of that enthusiasm went away because she was in a unit that she didn't really think about when she was in nursing school. And we're all excited when we pass the boards. But right when we start, sometimes that enthusiasm goes away. And I think somebody brought up that nurses are leaving after a year or two, right? So I think a lot of these new technologies, which can help with that satisfaction, they're not seeing it in the nursing schools. So just what are your thoughts on getting it to the schools and getting into the curriculum?
Oh, go ahead. Go ahead. All right. Well, I told you we would be fighting for the microphone. So, we all know, like, the ANA put a position statement on what it's required for nursing education as it relates to nursing informatics, but also the American Association of Colleges of Nursing has released core competencies that we must put into nursing education, and will really to identify, informatics, social media, emergent technologies, and really the impact. So it's about all of us, especially for many of us that are in academia, to ensure that the curriculum, it's right. And then the other piece is that I'm constantly bugging our nurse informaticists to see, can you come and teach our college? Because we need that. We need to start introducing our nurses to that. And then furthermore, I would say is how do we connect our nursing informaticists to that bedside nurse and having pockets of nursing experts at the bedside that can have that discussion with the nursing informaticist to say, I need to gather this data or document this. How can I best have a workflow that will enable me to do that? Because without data, we're not going to be able to change practice. And without our nursing informaticists being right there, helping us how to document that data, how to extract it, I'm not going to be able to help our nurses change practice.
I think we're fortunate at U of R, with our relationship with the School of Nursing, and we've had a lot of conversations with Dr. Kitko, who is the dean, around this very topic. And so I think one of the things to be very mindful of is they could have the best technology in those schools, and they have an amazing award-winning sim lab. They have all the tools. It almost looks like one of the rooms of the hospital across the street. The challenge is you can teach the function, right? This is how you use, and they teach Epic. This is how you teach or you document in the EHR. What we need to bring back to your point is how does that translate into practice? What is the informatics translation of what that means? Because the educators who teach those courses don't know that either. So how do we as informaticists partner with them to develop those curriculums, be partners with them in educating those teams of new nurses? Because at the end of the day, it's going to benefit us, right? Very selfishly, when those nurses graduate and come into our hospitals, they're so much more prepared.
And I'm going to use my moderator privilege here and jump in and make a comment. I do want to bring to everyone's attention, in case they're not aware, that in 2023, I believe it was, New York State passed a law that allows schools of nursing to use up to 30% of their designated clinical time in training in registered nurse programs, both AD and baccalaureate, as well as graduate programs. Now, this is initially motivated by the traffic jam in finding enough clinical sites for students across the board. But what it also does is loosen up the need for some clinical instructors and a variety of other things. So you now have a real vested interest in incorporating simulation and other types of technology, because you can make greater use of it in prepping your nursing students and counting that as clinical time for them. So the policy piece has a role here as well.
I just want to add to that because nursing, it's hard. Being a provider, it's hard. And so to have these simulation sites in which you can put students through really difficult situations in a safe environment, it's extremely helpful. In that way, they gain their confidence as they go to the bedside in having to deal with those really difficult situations, and having the backup of a faculty member telling them, oh, you did this really well, or maybe you need to work on this a little bit more. It's extremely important and helpful.
And one of the things you can do in simulation is let patients make bad decisions and see the outcomes of that. You cannot do that in practice as having done a ton of clinical instruction. You have to, stop, you have to stop people. So that's a huge value in actually learning from your errors, which we can do safely in simulation.
Great conversation. Oh, we have another audience. All right, we'll get the one audience question because we have one more. Do you want to? Or grab the mic.
Obviously, technology is wonderful and it can definitely help our practice. But as a licensed provider and AI and all this technology, how do you protect yourself and your license? I mean, AI can make things sound wonderful and real. We've seen photos that say, this is not real. It was AI. They can create anything. It can create a story that seems really believable. And how do you protect yourself in knowing the difference of what's real and what's assumed based on data from a computer?
So, I'm assuming that your question is on the generative AI, which can kind of produce, fabrications, or what we call hallucinations. What generative AI actually does very poorly is if you ask ChatGPT to go back and reference and cite where it produced its content, it will actually produce citations for you. And they'll look like real citations, but they aren't. They're not, real journal articles. Getting back to the original liability question, AI is a tool, and the decision-making process of you as the clinician, that still falls on you. You're going to have that liability, and it's going to be the onus, in my opinion, of the clinician to fact check the tool and what it produces. And so you can't take everything at face value of what comes out of the AI of being accurate. Now it will get better. And if you use prompt engineering and you're more specific and on the way you ask it to do something, again, I really equated it to a very studious and ambitious student that wants to please you and will get better. So, there are ways of teaching it or prompting it to be more accurate, but the liability falls on the clinician, in my opinion.
But I also think that's why we have to make sure that we are very mindful, and this sometimes scares me, that we're teaching critical thinking, because God forbid the EMR is down, and God forbid you didn't alert somebody that something was off. It does sort of, there's a crutch there to a certain extent that we didn't have when we were growing up, because we had to work with our brains to develop those critical thinking skills. I think it's something we need to think about, because I often get concerned that they're so reliant on the computer to tell them something that they're missing sort of the what's right in front of them in terms of the patient presentation.
I'd like
I
to add
have
too,
a-
from the vendor perspective a little bit, from the vendor, oh, sorry, I gotta stop.
That's okay.
Sorry, I didn't see
No.
this.
Go ahead. Go ahead.
I was going to say, I just have a funny story about that. It just is right on a nail on the head, but we have a chief nurse exec that while she was over at LIJ, they had the EMR go down, and they had not been on the EMR for that many years, but they were frantic. And her 9-year-old daughter said, "Mom, didn't you at one time use a paper and pencil? Don't you still have those papers somewhere?" And the truth was, it was God knows where, but the 9-year-old figured it out because at least she had once seen it. But we're getting to a point where if we don't, they were stopping, teaching script in school, right? People can't, I wrote a thank you note in script and the kid couldn't read the thank you note. It's not a joke, it's true. So there's historical stuff that we may have to archive, but nowhere to get it in an emergency. Technology will fail. And that was the one thing I wanted to talk about with the support. We have to be prepared for the failures in life, because the more we add, the more things can go wrong. And you can't just assume it's all going to be, roses and unicorns,
To teach our downtime procedures, right?
Yeah. Very
Okay,
important
one
part.
last virtual question. So I'm a med-surg tele staff nurse at North Shore University Hospital, and we're getting ready to start piloting a virtual nurse on my unit. Does anyone have any recommendations on how to make this pilot program successful?
I'm going to recuse myself because I know about that project. We're leveraging technology that we have now, but I think the best thing to know is it's not Big Brother, it's somebody to help you. And having that trust relationship as you go forward is going to be really important. But I'm going to leave it to other folks that know about virtual nursing as well, because I don't want to say too much.
Well, I just want to make a comment about nurse informaticists as project managers. One of the things you must do is always involve your frontline staff, subject matter experts. So that's my tip. Involve the frontline.
Thank you. So, yeah, Rochester?
No, no one. Oh, go ahead.
The virtual nurse. So I have our virtual nurse lead here, and let me see if I can speak to this as well as she can. There she is. One of the things that we're learning, especially in the situation you're talking about, is building a relationship and ensuring that there is that relationship between that virtual nurse and the in this particular case, I think it was a med-surg nurse. And so getting people to know each other, knowing that, and it may be possible or it may not be possible, but understanding that maybe it's one of their own staff members that can rotate through those positions. That those are also strategies that we've heard and we're deploying to make it more successful. And if you can't do that, it is giving them opportunity to learn about each other. And in that first instance, when they see how helpful that virtual nurse is going to be, that's going to change the tide. So always looking for early adopters, using those as champions. It's very traditional in terms of implementation approaches, but those can be very helpful.
Awesome. Well, I think we are actually at the end of the panel discussion. Boy, did that go by fast, right? So thank you so much. I'm sure we can go on for another hour or more. There's just so many things and so much to unpack with AI and nursing informatics and population health. But wanted to kind of close us out before we do our final close out with a raffle, actually. So I wanted to thank our speakers, our panelists. Thank you so much for taking the time, sharing your insights. I know we didn't have quite enough time with the number of panelists that we have, but I appreciate your time so much. And we're going to take a quick few photos here while we close out the session. So this is, I think we had mentioned earlier, this is our first time to actually do a totally hybrid event for New York HIMSS. And I would venture to say we are the first one who's done this. And we have somebody here from HIMSS National who can correct me if I'm wrong. So we wanted to be able to bridge the gap, and New York State is such a huge state, right? But we wanted to increase that collaboration between the metro area and upstate as well. So I think this is our, you guys are part of the inaugural portion where we've actually bridged the state. So thank you so much for your participation. Thank you so much for being here. And we wanted to thank again, all of this work for tonight will not be possible without our planning committee. So wanted to thank you to our planning committee and our collaborators as well. We appreciate it so much, Microsoft and RIT. The technology worked. We are, the technology works. So when we first were planning this, we thought we'll have an event in Rochester, and we figured, you know what, we are an informatics group. Why can't we do this virtually and hybrid? And we did it. So I think we've set the bar high. So we'll see what we come up with next time. But again, we're gonna get fun. Being nurses, right? We continually increase the bar. So we're just going to keep doing that for sure. Again, we want to thank our partners and our sponsors for being here. We have until 8:30. Please go out and network and ask questions. I'm sure there's going to be a lot of questions more for our panelists and speakers as well. But we wanted to kind of take a chance to do that. And then we're saving the best for last because we wanted to encourage an in-person networking. So we did have some raffle prices for you. So I'm going to ask Olga to come up and do some raffles. Oh, yes. While we're doing that,